Today, I want to bring you a case, an original investigation that's published at the JAMA Network. It's a free, full article that you can get now and start reading because many of you will be doing your observerships with internal medicine docs, cardiologists, residency programs, and this is something that we get in the emergency department very often. We get patients that complain of chest pain, troponin elevation, and now with the vaccinations, it is true that we get cases of young people, young males, complaining of chest pain, and if you're not aware of the recent side effects, noticed side effects of the vaccines for COVID, one of them is viral acute myocarditis. Now, it is very similar to the presentation with viral myocarditis. It's very similar to an ACS case. So what should we do? Are we going to catheterize every single patient that comes with an elevated troponin and chest pain? Now that we have more and more information that side effects of vaccines are seen and are causing cases of myocarditis. So this article that has collected information from a very good large amount of patients is bringing to light that it is causing myocarditis, the vaccines are causing myocarditis more often in young male patients than their counterpart female. The presentation is 1 or 2 days post-vaccination. The symptoms rapidly subside with pain management, and usually you don't have to do much more than just monitoring in a telemetry unit. So why is this important? And why does this matter to you in your observership, in your rotations, now that you are applying? Because a lot of the cases that you will see are going to be COVID. And what is the pathway for a patient that comes with ACS? First is to stratify the patient based on age, based on presentation, based on the quality of the symptoms, and other laboratory or imaging. So you will do the same for this patient all the way to stratification based on age, sex, race, information, presentation, and laboratory findings. And all of these, till this point, will look like an ACS. We have to rule out NSTEMI, STEMI, but it is possible now that this could be a myocarditis secondary to a recent vaccination. But how do you prove this? You still have to get an echocardiogram to make sure that there is no underlying heart disease, because we see underlying heart disease with very low ejection fraction in patients, for example, with cocaine addiction, methamphetamine addiction, alcoholism, morbid obesity, and you still have to get your echocardiogram to see if there is any sign of ischemia. Then you still have to get an EKG. And then some doctors will say, well, let's do a cardiac MRI. And a cardiac MRI at that point, if your facility has it, which not many facilities have availability for a cardiac MRI, could give you enough information to stop there and say, this is viral myocarditis, is consistent with the side effects of the COVID vaccine, leave it there, patient can leave, can go home, he will be fine. But if you don't have an MRI, in some facilities where there is not enough information, where doctors are not up to date to what is new, they will be like, we have to do an angiogram on this patient. We have to go all the way and find out what's going on. Why is he shooting up his troponins? So I believe that this, once you go through this study, once you dissect the information that is presented here, which it's in the conclusions, once you have this and you present this during your observership, during your rotation with your attendings, you get the case of troponin elevation on a young patient, and you say, Dr. Munoz, this is a case of a viral myocarditis. I just read this study that clearly shows how male patients are more affected than female. I think that we have enough information based on the recent exposure to the vaccine. the normal EKG, normal echocardiogram, normal normalization of troponins after 2 days, and resolution of symptoms, I think we are good to release the patient without need for an angiogram. And I will be like, okay, that sounds good. That sounds very reasonable. It seems like it is a case consistent with myocarditis from the vaccine, and you will get your letter of recommendation. So, when is a good moment, a good time to bring up this study? Um, so you have to have your notes. You have to have read the study. You have to have your little notes, a short 2-minute presentation, and you very professionally have to present this at the end of the discussion of a patient that you're just seeing when you're attending, or during rounds if you're doing an observership in an internal medicine residency program. At the end of the rounds of a COVID patient with myocarditis or troponin elevation, you can say, "Hey guys, I would like to present this topic that I just read at the JAMA magazine, and this will be very well uh, taken. This will be welcomed, and because residents and even attendings don't have much time to go through all the recent information, the new information. So if you can bring it very well dissected, presented in a very professional way, I believe this could very well impact on your rotation. So keep it in mind, it's a great study, it's free. I will definitely do a presentation on this. I will talk to my attending on this. I will have a copy with me and give it to them during the rotations. Well, thank you.